next speaker this morning is Dr. Michael Mitchell. Dr. Mitchell attended Touro University College for medical school. He then went to residency at the University of South Carolina and completed his fellowship at UT Southwestern up in Dallas. He joined Dell Children's in 2020 and leads research endeavors here involving solid tumors and circulating tumor DNA, and is also actively involved in our education of the residency program. The title of Dr. Mitchell's talk today is Abnormal Labs, including ITP and Neutropenia, and a Systematic Approach for the Primary Care Physician. Please welcome Dr. Mitchell.
Thanks, Ginger. Good morning, everyone. Great to see so many people here on a Saturday, like Alicia said. My talk today is pretty low level, but kind of more broad. So I think something that general pediatricians probably see a lot are maybe one abnormal lab value that they weren't even looking for whenever they saw a kid and sent a CBC or another panel of labs. And I want to talk about some, differentials for some of those values. Objectives today, we'll discuss common lab abnormalities in primary care, differential diagnosis and diagnostic approach to abnormal hematologic indices, and some current management of ITP and autoimmune neutropenia, which are some of the more common hematologic disorders that we see. And I'm not going to have any really long case outlines, but if anyone has any questions about a scenario that they've seen before or something that they feel that pops up frequently, please feel free to interrupt me and we can discuss that. And I have no relevant financial disclosures. So first, going to talk about coagulation some. I'll totally defer to Dr. Priola as far as the management of true bleeding disorders and bleeding dysfunction, but I think it's fairly common for pediatricians to send coags whenever they have someone with nosebleeds or what seems to be easy bruising, or maybe a female with dysfunctional or heavy menstrual bleeding. So the first thing I think someone should do, and the first thing I think about whenever I get a call as office doc about abnormal coags, is really to look at true normal values for pediatric patients. As Alicia said, with anemia, the values for PT and PTT vary widely by age, and CPL, Quest, and even our lab here, they just have kind of one range that they say is normal for any age, and that's really not true. So the first thing, as far as trying to decide if you're actually working with a disease, is to look at the Harriet Lane Handbook normal values, and I do that anytime I get a call about this. If the elevation is like pretty trivial, like 10% above or below the normal range, that's usually not going to be indicative of actually disordered bleeding, but it may be indicative of like a carrier state. So things that would prolong both the PT and the PTT would be liver disease, and then if you have severe vitamin K deficiency, then both the PTT and the PT could be prolonged. Maybe you have someone with an isolated prolonged PT. So this is where more mild vitamin K deficiency could be the cause of this. And so who might be vitamin K deficient? If you have a kid who recently maybe had an ear infection, completed a course of amoxicillin or augmentin, then certainly they could be vitamin K deficient from that. Other kids who might have a primary fat malabsorptive disorder, since vitamin K is a fat-soluble vitamin, or other primary GI pathology can cause vitamin K deficiency. And then factor VII deficiency would also be an inherited cause of isolated prolonged PT. It's pretty rare, 1 in 300,000 people, as opposed to like factor VIII and IX deficiency occur in about 1 in 10,000 to 30,000 male births. Factor VII deficiency is inherited autosomal recessive, whereas the others are X-linked, so pretty rare. Causes of isolated prolonged PTT. So again, inherited factor deficiencies like the hemophilia A, B, and then hemophilia C, which is Factor 11 deficiency is even more rare than factor 7 deficiency. It occurs in about 1 in a million people, but this would cause an isolated, quite prolonged PTT. A mildly prolonged PTT could be seen like in females who are carriers of hemophilia A or B, and also some females or some males as well who have von Willebrand disease could have a prolonged PTT, although von Willebrand disease could have also a normal PTT as well. Another cause of prolonged PTT, which is a little confusing to think about and is sometimes surprising, is lupus anticoagulant. And so this doesn't mean the patient has lupus, although this is the patient population that it was first kind of discovered in, is there were some patients with lupus who had prolonged PTT. Because the PTT is prolonged and we think that means you are more at risk of bleeding, then it was called lupus anticoagulant, although this is actually potentially a hypercoagulable state. It can follow infectious illnesses as well. So you have a kid who recently got over a cold or some infection, and they have some bruising, or maybe they're about to have surgery and you felt compelled to order coags, and they have a very prolonged PTT. If they have no other evidence of bleeding and no family history, then probably would follow that up with another PTT in about 12 weeks, because these transient lupus anticoagulants after like an infection usually resolve in that time. They can be associated with autoimmune disorders though, so if you have the right history of someone with any autoimmune stigmata, or you think they might have a rheumatologic condition, it could be a lupus anticoagulant that doesn't necessarily get better with time. When it's transient, also, those kids aren't really at risk of clotting. That's not seen very often. For a good portion of this talk, I'd like to talk about thrombocytopenia. This is something that we see fairly often, and it's usually found whenever you're looking for it. And so if a pediatrician sees a child who has nosebleeds or heavy menstrual bleeding or a lot of bruising, and they get a CBC and the platelet count is low, then where do we go from there? These are kind of the different ranges. So when I think about a platelet count of 100 to 150,000, that's mild thrombocytopenia, and I wouldn't really expect that to cause any easy bruising or bleeding. Even neurosurgery is usually okay with a platelet count above 100,000. For moderate thrombocytopenia, a platelet count of 50 to 100, I feel like that can cause some increased bruising and maybe mild bleeding with trauma, but we usually clear kids for contact sports even between 50 to 100. And then severe thrombocytopenia is a platelet count below 50,000, which should cause pretty easy bruising, but spontaneous bleeding and severe bleeding is usually not common, but it depends on what's causing it. So one cause is drug-induced thrombocytopenia, and I think the most likely culprit that I think of is valproic acid or Depakote. And so if I ever get called about a child who's on Depakote and has thrombocytopenia, then that is usually considered to be the cause unless proven otherwise. Other less common drugs, other psychotropics, and sometimes antidepressants or antiepileptics can cause thrombocytopenia, and nearly all of these medicines can also cause platelet dysfunction. And so even if the platelet count is just mildly low, but they have a lot of bruising and bleeding, it could be because they cause platelet dysfunction. And that's something that's not necessarily accurately measured on a platelet function assay. They can be abnormal, but they might be normal, and that doesn't mean it's not the reason for the easy bruising. ITP, so this is probably the most common reason for severe isolated thrombocytopenia in kids. When a child has prolonged nosebleeds or recurrent nosebleeds or extensive bruising, of course, low platelets are the first thing that we think about, and it's right to get a CBC. Any severe thrombocytopenia, I think, hematology should be called, and we should see those kids pretty soon. But anytime a pediatrician's seeing a kid in the office with a lot of bruising and they find a severe lab abnormality, then knowing how to prepare the parents and kind of what your gestalt is for what's causing it. Something that I think leads you one direction or the other is the chronicity. So if it's a healthy kid who has been acting totally fine and they were normal one day and then the next day they were covered in bruises, we often think ITP rather than leukemia or something like bone marrow failure, aplastic anemia, Fanconi anemia, something like that. If it's more indolent, so they were normal, but then they had a bruise here and there, and then more and more bruises and a nosebleed, and then the next week they had a couple nosebleeds, then I would think less likely ITP. Other things, of course, being like bone pain, we would not think ITP, we would think more concern for malignancy. Fever, lymphadenopathy, hepatosplenomegaly, also less likely ITP. To truly diagnose someone with ITP, you should look at the blood smear. So just because someone has a CBC with isolated thrombocytopenia, that doesn't diagnose ITP. You should have someone look at the blood smear, so we always try to do that as hematologists, and we should see large platelets on the blood smear because the cause of ITP is that the immune system is causing platelet destruction, and then the body starts usually making more platelets, and those brand new platelets are larger. They also work better than old platelets. So if you see a kid with thrombocytopenia, but you don't see large platelets on the smear, you should really not be confident that it's ITP. Another clinical scenario where it makes you more confident in the diagnosis is if the child just had a viral illness maybe 1 or 2 weeks prior, or if they recently had an MMR or COVID vaccine. Those are notorious for causing thrombocytopenia. It often resolves in kids. It's more common to resolve spontaneously, 80% within 6 months. That's even more common in infants. So about 90% of infants or toddlers with ITP, they'll recover within 6 months and usually really before then. But older children, less likely to spontaneously resolve. That may also be because older children are likely to have co-occurring autoimmune disorders like lupus or immunodeficiencies. So common variable immunodeficiency is likely to cause ITP. It's also likely to manifest later in childhood. So that's something that we usually think of if we have an older kid who's diagnosed with ITP, especially if it doesn't spontaneously resolve. There's no medical cure. There is a surgical cure that it used to be thought of as more of a cure, and we're using it less often now. But there's really no medicine that we know of that can just reverse the insult to the immune system. It just needs time to kind of reprogram itself. But there are multiple interventions that we can use to raise the platelet count temporarily if it is needed. Again, like I said, any severe thrombocytopenia, I think hematology should be called and that kid should be referred. Definitely any platelet count below 20,000, they need to see us within 24 to 48 hours. That's a very well-established recommendation from the American Society of Hematology. If a platelet count is like between 20 and 50, it may be reasonable if the kid looks really good. Of course, I think call us, but if they live a long way away, if the family really doesn't want to come see a subspecialist yet, repeating it in about a week and see if there's any trend could be reasonable, but I still think a conversation with us is pretty necessary. ITP can usually be managed as an outpatient, but there are definitely caveats. So if the diagnosis is uncertain, this is not a classic history of a kid got his MMR vaccine a couple weeks ago and then was covered in bruises. If there's been weight loss, if there's lymphadenopathy, hepatosplenomegaly on exam, then that's likely not ITP, and they should probably be admitted to the hospital with a platelet count of less than 20,000. If there are social concerns, so if there's been poor follow-up at the PCP's office and now there's this severe abnormality, then that kid could need a hospital admission. And then also, if they're a long distance from the hospital, of course, the family's going to be counseled that you're going to see the hematologist in 1 or 2 days. But if there's a lot of actual bleeding, then you need to come to the hospital. Well, if they're 2 hours away, then that's a lot of bleeding before it's actually being managed. And that gets into which of these patients actually need to be treated. So major bleeding, of course, if someone's having hematochezia and a CBC is obtained in the PCP's office and the platelet count is 10, no doubt that kid needs to be treated. They need to come to the hospital right away. Non-major bleeding, so prolonged nosebleeds lasting like longer than 10 minutes, that kid needs to be treated. If there's maybe a child who had a nosebleed once a week and it lasts just a couple minutes, that's not as cut and dry, not as clear cut. Hematuria is definitely an indication for treatment, and then also wet purpura, so something that, of course, the child is probably not going to tell you and the parent might not see, but to look in the mouth, and if there are any purpura in the mucosa there, then that's an indication to treat ITP. The most recent ASH guidelines regarding the treatment for ITP, also diminished health-related quality of life is recognized as an indication for treatment. So if you have someone who plays sports and it's very important to them, and they've been an athlete all their life, and now they have this condition that we don't think is a serious detriment to their health, they're not actually bleeding, but they can't play sports anymore, then that's being more recognized as a reason to treat kids. And then, of course, it could cause heavy menstrual bleeding, or if someone is just covered in bruises and very self-conscious about that, and the platelet count is severely low, they're not bleeding, but if it's severely affecting their quality of life, again, it's recommended now to consider treatment in those patients. One of the major hematologists who created the ASH guidelines, I saw her give a talk a few years ago, and she said she actually doesn't even look at the CBC until the very end of the visit. So if there's a patient she follows with ITP, they get the CBC, she goes in, she talks to them about how life is, and then they decide a management plan, and then at the end of the visit, she and the patient look at the platelet count together, but they've already made the plan based on how life is really going. So the first-line treatment that's kind of been established for decades is IVIG. This is given as an infusion, takes several hours. It can be given as an outpatient, but logistically, it's pretty hard to arrange that. So it's usually given as an inpatient. It's often well tolerated. There are some side effects, though, which can kind of cloud the picture of ITP. So neutropenia is one of them. About 10 to 20% of kids who get IVIG can become neutropenic. Usually not to a degree that really compromises their immune system, but if you see someone with isolated thrombocytopenia, you give them IVIG, you see them a week later, and now they're neutropenic and still thrombocytopenic, then you're thinking of bone marrow failure or leukemia, and it might just be because of the IVIG. It can also cause hemolysis, usually not to a degree that's severe, but sometimes it can be. And then the other one is aseptic meningitis. So we worry about intracranial hemorrhage in anyone with a platelet count like less than 10,000, although that is a spontaneous intracranial hemorrhage is very rare with ITP. But if it's on your mind and you know the platelet count's been very low, and then that child develops severe headache and vomiting, then you're likely going to be concerned about a hemorrhage, and they'll need to come back to the hospital and get a head CT. But usually very well tolerated, and it raises the platelet count in most patients within a couple days. The other, what's recognized as another first-line treatment right now, although I think most of us still think of it as an option behind IVIG, is corticosteroids, so prednisone or dexamethasone. It can be given anywhere from 4 to 14 days in duration, and it's probably equivalent to IVIG as far as the response rate. and maybe even preferred by some. So in adults, this has been the first-line treatment over IVIG for many years. It can definitely be given as an outpatient. That's another major advantage of it, and it doesn't cause the symptoms of aseptic meningitis, doesn't cause neutropenia or hemolysis, but it can have side effects of like irritability and dysphoria, increased appetite, which can actually keep kids up all night and sometimes is just fine and funny for a couple days, but sometimes it can be debilitating. And then insomnia. I think as hematologists and oncologists, the reason that we have apprehension to giving steroids is because there's some level of anxiety in treating kids who haven't had a bone marrow exam and not knowing that they don't have leukemia. Although this is not necessarily backed up by any data. Like the recent standard risk ALL trial, AALL 0932, they looked back at every kid enrolled on that study, and none of them had gotten steroid treatment for presumed ITP for isolated thrombocytopenia. But we wouldn't ever want a PCP to give steroids to someone without having seen hematology. We should be making that diagnosis. We should be looking at the blood smear, making sure the kid doesn't have splenomegaly, and really thinking it through. But if anyone sees a patient of ours who had gotten steroids instead of IVIG, it is recognized as a first-line treatment. Another treatment, which is a surgical cure for ITP, or it used to be thought of as more of a surgical cure, is a splenectomy. So as recently as 30 years ago, this was the standard second-line treatment. So if someone had gotten IVIG and didn't respond, they got a splenectomy. That was fairly standard. 2011, it was still recommended to consider if the first-line treatment had failed, but that is not common at all now. So if you get splenectomized, there's still a 30% chance that you still have ITP. And so that's pretty disappointing, especially then when you've making someone at risk lifelong for encapsulated bacteremia. And we've all heard actually of people who have had their spleen out as children with ITP and then grown up as adults, forgotten that they have to go to the ER and get empiric antibiotics right away if they ever have fever. And there are lots of people who have died of bacteremia just because they forgot they had to take that precaution whenever they were adults. Now in 2019, the most recent ASH guidelines for ITP, there are at least 7 options preferred over splenectomy. It's something that's it's really avoided. And one of those options that's gotten a lot more popularity over the past 10 years are thrombopoietin receptor agonists. So IVIG and steroids and splenectomies, the way that they're thought to work is by decreasing platelet destruction. So platelets, an autoantibody attaches to platelets, and then whenever those platelets go through the spleen, they attach to the reticuloendothelial system. IVIG and steroids both stop the binding of macrophages to those platelets when they're engulfed by antibodies. And these thrombopoietin receptor agonists work in a very different way. They just stimulate the production of more platelets, which doesn't make really sense to me because our body starts producing more platelets if you have ITP, but somehow this actually really does work. If you overcome the amount of antibody destruction by just producing more and more platelets, the platelet count often really does increase. We use this in refractory cases or prolonged cases. So if you have a child who has ITP, doesn't respond to IVIG, doesn't respond to steroids, maybe they even get rituximab, which is another option. Vincristine is another option, which I don't think we use that often, but something that you could. And they're still having severely low platelet counts. I think of these medicines within several weeks of diagnosis sometimes. Thank you. Something else to think about, MMR vaccine and ITP, I mentioned that earlier. So this was the only vaccine prior to COVID vaccines attributable to ITP. It occurs in about 1 in 20,000 doses. So not too infrequent. There's a very high rate of spontaneous remission after MMR vaccine-mediated ITP. Infants who have had ITP before 1 year of age, they should still get the MMR vaccine. And if they have ITP after 12 months vaccines, it used to be recommended to always give the second MMR vaccine. Now it's recommended that you can consider titers, and if they have low titers, then re-immunize. But if they still have immunity, you can defer the 4-year vaccine. Macrocytosis, I want to talk about as well. Alicia touched on this a little bit, because I think sometimes you're not even looking for this. Like you get a CBC just at a regular well check, and maybe they're not anemic, they don't have thrombocytopenia, the white count is normal, but they have macrocytosis. Alicia mentioned like B12 and folate deficiency. Another thing that can cause macrocytosis or macrocytic anemia is copper deficiency. And I think it's important to get across that these are not benign disorders. So they could suggest GI pathology. Copper is absorbent in the stomach, and so it's common in J-tube fed children. But whenever you replete copper, you can actually give it in a J-tube, and some of it still gets absorbed. I don't know why, but it usually works if someone actually just can't tolerate any feeding into their stomach. Bone marrow failure and leukemia, macrocytosis, high MCV could be the first sign. But another population where this is very well explained is Down syndrome. So kids with Down syndrome are supposed to have a yearly CBC because they are high risk of developing leukemia. You may see macrocytosis in one of those children. This is totally normal. Their mean MCV is actually around 100, which seems pretty high. But if there are no other abnormalities, then they don't necessarily need to be referred. Lymphopenia is also common. And then something else that you might see that is, of course, not anemia is erythrocytosis or polycythemia. So elevation of the hemoglobin, hematocrit, or RBC mass. This is worrisome because in severe states, it can cause hyperviscosity and even like thrombosis. This is usually not worrisome unless their hemoglobin is like 18 or higher. And to think about the differential in these patients, there's a hematologic disorder, polycythemia vera, or CML can cause increased like overactive bone marrow that causes erythrocytosis. But those are low erythropoietin states. There are also high erythropoietin states that are kind of secondary hematologic disorders. Dehydration can also cause spurious erythrocytosis. So maybe if someone has unexpected high hemoglobin, maybe they're dehydrated whenever that was obtained. Repeating it about a week later when they're more hydrated is totally reasonable. And also important to consider in adolescent males, a hemoglobin up to 16 is within normal range because testosterone stimulates erythropoiesis. So this is a consult that we get, I think, fairly often that is not necessarily worrisome, but it's reasonable for these kids to be followed closely for a little bit and maybe some other things ruled out. The first thing that I usually do is get an erythropoietin level, and so if it's elevated, things that we would consider are heart and lung conditions, smoking or vaping, important to take on the history, high altitude, so if someone spent the summer in Colorado or something, then they would likely have elevated erythropoietin and elevated RBC mass. Less common would be erythropoietin secreting tumor, and then a high affinity hemoglobin, so a hemoglobinopathy where it attaches to oxygen more tightly, doesn't deliver it to the tissues, so the body is stimulated to make more hemoglobin. Neutropenia, another common reason for referral, something that can be very anxiety-provoking, reasonably so, because it can make the immune system weak depending on kind of what the level is and what the cause is. Again, the ranges, so an ANC of 1,000 to 1,500, likely very little infectious risk, even in infants. Anything above 1,000 is normal. Moderate neutropenia, I typically think mild infections, what may be like a sinus infection may just turn into something a little more prolonged with moderate neutropenia. and severe neutropenia, an ANC less than 500. You may have opportunistic infections like odd bacteria or fungus infections, and minor insults can become severe. So if someone has like an abrasion that in someone with a normal immune system, it may resolve spontaneously. That may turn into more of a cellulitis. Along with drug-induced thrombocytopenia, so medications are a reason that someone may become neutropenic. Bactrim is a very common culprit of this, and some other antibiotics as well. Also some psychotropics, and I think it's important to say the duration of exposure can be days to months prior to onset of neutropenia and sometimes even years. So if someone was taking one of these medicines that causes neutropenia and their counts were always normal, but then years later they become abnormal, it still could be the medication. And it's not always a reason to discontinue the medication. I think just everything needs to be taken into account. A cause of neutropenia that we see often, previously called benign ethnic neutropenia occurring in African Americans, it's now known as Duffy null genotype. So this is prevalent in areas endemic for malaria like Africa. And Duffy, it's an antigen on red blood cells. And if someone is homozygous for a null genotype, that's actually protective against malaria. And they have abnormal neutrophil morphology that just causes egress out of the bloodstream into the tissues. These individuals have normal neutrophil production and function. There are ways of doing a genotype for Duffy or red blood cell antigen testing. We don't typically do that, but I think in time that might become more common. Something that is a very serious disease, severe congenital neutropenia, discovered in frequently febrile young infants who have infections. Several different genetic disorders can cause this. These infants usually have mouth sores, pneumonia, and gingivitis, and it may transform to leukemia. So this is something that we follow very closely. And other disorders that can also be due to genetic mutations and can be very symptomatic, cyclic neutropenia. So these kids, they can also have fevers and mouth sores, usually not severe infections, but sometimes they can. And classically, they have these cycles, 21 days in duration, where their neutrophil count goes up and down, but they are not usually at risk of leukemic transformation. And then something more common that we see where they can have a very severe low neutrophil count is autoimmune neutropenia. So this usually manifests in infants to toddlers, and it's discovered often during febrile episodes when someone gets a CBC, but maybe there's not a serious infection going on. If you look at the CBC and they have an elevated monocyte count, then that usually would make you think autoimmune neutropenia, but there's no good test for it. So there is an anti-neutrophil antibody test that you can order. It's fairly specific, but it's not sensitive at all. So we often get those, and if it's positive, it helps us with more confidence in the diagnosis. But really, any severely neutropenic infant, we're going to follow closely. And when we initially see them, we're going to give them fever precautions to come to the ER or clinic with any fever to get a blood culture and empiric antibiotics. But if a few episodes go by where they don't actually have bacteremia, they don't have any infection at all, they do fine, it usually makes us think this is autoimmune neutropenia and not an actual bone marrow failure disorder. So really just time and patience are essential. Sometimes even whenever you see a child who's recently been severely neutropenic, but they have fever, then their neutrophil count is much higher and normal, that also makes us think this is probably what's going on. Often, we ask, did they have a normal neutrophil count earlier in life? And if it was normal, sometimes it makes us think, yeah, it's probably autoimmune and not severe congenital, but that's not 100%. There's some kids with severe congenital neutropenia who at some time earlier in life can have a normal neutrophil count. We don't usually marrow these kids. That used to be more common, but now if it looks like autoimmune neutropenia and that's how they're kind of behaving, we usually don't marrow them. And once the diagnosis is established, they've had several febrile episodes and done fine, had no infection, especially if their neutrophil count is known to go higher during the fever, then they can usually be treated as normal children, but we still follow them until resolution. GCSF, Neupogen or filgrastim, this is a daily injection. It can be given not quite daily, but maybe once or twice a week. It used to be given much more commonly on autoimmune neutropenia. This is not routinely recommended now. Very seldom we'll give GCSF to kids with autoimmune neutropenia if they happen to have like very frequent fevers or for sure infections. But it's used for cyclic neutropenia and severe congenital neutropenia as well. So abnormal labs, a one-off, something maybe you weren't expecting. The way I usually approach it is first thinking, is it really abnormal for age? So looking at a table in Harriet Lane and then thinking what else? What was their recent history? Did they have an infection recently? Common for hematology to co-manage manifestations with other specialties. So if someone has a secondary polycythemia or someone has anemia from a GI disorder, it's common for us to see them even if it's not a primary hematologic disorder. If there's a mild abnormality within maybe 10 to 20% above or below normal, I think it can be reasonable to repeat it in weeks to months. But a single severe abnormality, so like 50% below or above range, or if there are multiple mild abnormalities, or if they're symptomatic of whatever the lab value is, then call us anytime, but those are kids who they should usually be referred. And even if we're not doing anything about it, the education, talking to the family, giving them a place to go whenever there are concerns about this new abnormality is necessary. And any questions? Thank you.
Thank you, Michael.